Good morning. Good morning, ladies and gentlemen. Oh, there we go, the microphone. I thought I was going to have to shout. Welcome to the University of Nottingham, and welcome to the second Vice-Chancellor's lecture. My name is Alex Miles. I'm the Director of Global and Political Affairs here at the University. We are delighted to have you all here for what is going to be a fantastic hour of discussion and debate about the future of public health. Just to give you some housekeeping notes, phones on silent please, but do tweet using the hashtag #AskTedros. It is also the 25th anniversary of the University of Nottingham's Masters for Public Health, and again, please do use the hashtag UON25MPH on social media as well. The format of the next hour, which is being live streamed across the world to our overseas campuses in Malaysia and China, where I know people are watching now, will be as follows. The Vice-Chancellor will arrive on stage and introduce our two esteemed guests. They will then open with an initial 5-minute response to the questions, and then we'll go into conversation. Please use this time to start thinking of questions for our guests. I am also monitoring on social media, and the Vice-Chancellor will call on me throughout to field and provide questions to both. So, without further ado, could I introduce the University of Nottingham's President and Vice-Chancellor, Professor Shearer West.
Thank you, Alex. And it's so great to see so many people here. I'm sure we're going to have a great hour of conversation. So this lecture features as part of an all-day conference celebrating the 25th anniversary of the Masters in Public Health course at the University of Nottingham. So the theme is moving forward, the next 25 years of public health. And the day is an engaging program which focuses on reflecting on past achievements, but also future priorities and challenges. So throughout the day, those of you staying all day will hear from distinguished colleagues on global, national, and local public health priorities and challenges, and hear personal stories of success. The Vice-Chancellor's lectures are a series of public lectures that bring some of the world's foremost thinkers, figures, and influencers to the university to speak to students, staff, members of the public, and our civic, business, and community partners. Many of these will have a connection to Nottingham, but this lecture features two leaders in global health with a particularly strong link to the university. Professor Jonathan Van Tam is a world-leading epidemiologist and professor of health protection at the University of Nottingham. During his 25-year career, he has advised the World Health Organization, the UK government, and the European Centre for Disease Prevention and Control on influenza and other respiratory virus infections. He's also a Deputy Chief Medical Officer for England, one of the most senior advisors on health and medicine in the UK government. Dr Tedros Adhanom Ghebreyesus graduated from the University of Nottingham in 2000 with a PhD in public health. He served as Ethiopia's Minister of Foreign Affairs and Minister of Health, improving access to health care for millions of people. Under his leadership, Ethiopia was noted by the UN as one of the success stories in terms of achieving the Millennium Development Goals. 3 of the 8 goals dealt directly with health. Beyond Ethiopia, Dr. Tedros' global leadership on malaria, HIV/AIDS, and maternal and child health has been immensely impactful. He was elected as chair of the Global Fund Fight AIDS, Tuberculosis, and Malaria Board in 2009, and previously served as chair of the Rollback Malaria Partnership Board and co-chair of the Partnership for Maternal, Newborn, and Child Health Board. Dr. Tedros was elected Director General of the World Health Organization in 2017, and I'm very pleased to see that we have just this morning given him an honorary degree. So could I welcome Professor Van Tam and Dr. Tedros to the stage to give short presentations. Thank you. Speak for a short period, and who would like to go first?
I think I'm going to go.
Okay. Thank you.
So, good morning, ladies and gentlemen, and Vice-Chancellor, thank you so much for the invitation. It's an enormous pleasure to be here, but perhaps quite a strange one because I'm still a member of academic staff here at the university, but as you know, seconded to the UK government at the present time. The subject of the debate we're going to have today is about global public health threats. And of course, I know that many of you in the audience know that I'm an influenza epidemiologist and have been for about 27 years now. Not to play down influenza, which is a persistent, difficult and recurrent public health problem that continues to cause problems around the world. But of course, the global public health field is much wider, and the UK government is very committed to supporting global public health in a much wider sense. And if I were to quickly summarise, the areas of difficulty and challenge that I think we see ahead are ones where the nature of the existing threats is changing over time. Climate change, environmental degradation, and the increasing difficulty of working with conflict and population movements. I think we also recognise that much as I'm an infectious diseases epidemiologist, the global burden of disease is changing, and the rise of non-communicable diseases is really quite significant. The continent of Africa is a key example of where things by 2030 will have changed very dramatically. I think we also see health systems as continuing to be vulnerable, and I don't there refer just to the low and middle income countries where the health systems themselves are at present sometimes underinvested and relatively weak. I think about the vulnerability of developed healthcare systems too, in terms of the threat from antimicrobial resistance, for example, and the fact that routine surgery that we take for granted may one day be extremely challenging if we don't get on top of that problem. Inequality continues to exist between and within countries, and I think we would all say that the world has been slower than it should have been in taking action, determined action on the wider determinants of health. And the final point I'd make is that I think we now live in an increasingly complex world where the coordination of an international and a multilateral system is becoming very challenging indeed. I think I'll stop there and pass over to my colleague.
Thank you, John. Thank you, Vice-Chancellor. And good afternoon. I think is it already good afternoon? Not yet. Very nice to have this opportunity. And it's, as I said in the morning, it's such a great honor to be back in my alma mater. As I said in my remarks at the graduation ceremony this morning, this is the first time I have been back to Nottingham since I graduated in 2000. By the way, 2000, millennium, we used to be called the millennium graduates. But as a proud alumnus, the University of Nottingham holds a very special place in my heart. The year 2000 wasn't quite 25 years ago, but it's amazing to think how much global public health has changed in that time. Globally, life expectancy has increased, maternal mortality, neonatal mortality declined significantly, malaria deaths and also deaths due to AIDS have declined significantly. But what will health look like 25 years from now? If current trends continue, we will live longer, but we will live healthier. In September 2015, world leaders adopted the Sustainable Development Goals, covering everything from poverty, education, and health to economies, institutions, the environment, and the seas. The SDGs are the world's to-do list between now and 2030, although many of their themes will extend beyond 2030. For health, the center of gravity is the target to achieve universal health coverage globally by 2030. That's WHO's top priority because it's the one target that, if achieved, will enable the achievement of the other disease-specific targets. We will continue to need specific programs for specific challenges, such as to end the epidemics of AIDS, TB, and malaria, to finish the job of eradicating polio, to prevent the spread of antimicrobial resistance, and to address the burden of non-communicable diseases and mental health. But those programs cannot ultimately be successful unless they're rooted in health systems that address full range of a person's health needs from the cradle to the grave. Currently, at least half the world's population lacks access to essential health services. And every year, almost 100 million people are pushed into extreme poverty by the costs of paying for care out of their own pockets. That's the scale of the challenge we face. But it's also an opportunity because the benefits of universal health coverage go far beyond health. UHC is also a platform for development. It reduces poverty by removing one of its causes. It creates jobs for health workers. It stimulates productivity and economic growth by getting people off their sick beds or back to work. It improves gender equality because it's often women who miss out on health services, and it helps to protect countries against the effects of outbreaks and other emergencies. Health systems and health security are two sides of the same coin. Sorry, it's a bit closer. I'll repeat this, health systems and health security are two sides of the same coin. We're only as strong as the weakest link. The key challenge here is for countries to invest more in emergency preparedness rather than only emergency response or firefighting. The current Ebola outbreak in the Democratic Republic of Congo is a case in point. So far, more than $250 million has been spent fighting Ebola in DRC. And we will have to spend a lot more to end the outbreak. In Uganda, $18 million was spent vaccinating health workers and other preparedness measures. As a result, when a family with Ebola crossed the border from DRC into Uganda a month ago, Uganda was ready, and there has so far been no transmission, no local transmission within Uganda. Countries that invest in preparedness will save lives and save money. The third major challenge is to address the environmental, economic, commercial, and social determinants of health. As I said this morning, and as John also said, health does not exist in a vacuum. Many of the determinants of health lie outside the health sector, in urban planning, energy, transport, trade, and commerce. Major demographic trends like urbanization, migration, and aging populations, plus the existential threat of climate change, all pose significant challenges for human health. Addressing these trends is a challenge, but it's also an opportunity because countries that take a health in all policies approach will promote health and prevent disease, and therefore enjoy a triple dividend in terms of health, social, and economic benefits. And that's why health with education is taken as human capital. Ultimately, the future of health must be about promoting health and well-being and not treating disease, meaning keeping people out of hospitals. Universities will play a key role in all of these challenges and opportunities. Science and research are critical for giving us new tools and for showing us what works and what doesn't. Advances in digital technologies, big data, medicine, genomics, imaging, and the social sciences will all play a vital role, especially social science, behavioral science. 25 years from now, we will have a new set of challenges and opportunities. But my hope is that we will look back and be proud of the progress we have made, not regret that we missed the opportunities we had. Thank you very much.
Thank you both very much. There's a lot of food for thought there, and I'm sure there will be people in the audience who will want to ask questions, but I'm giving them a little time to think. You're both talking about the incredibly complex environment, that global environment we live in now. But we are celebrating 25 years of public health teaching at the University of Nottingham. And so looking back to 1994, we had the joint UN program on HIV and AIDS was just being launched. It was before the Millennium Development Goals. Global health funding was just a fraction of what it would become over the following years. What do you think is the biggest single advance we've had in global health over the last 20, 25 years or so? I'm happy for anybody to start with that.
Okay, well, maybe I'll start then and say that clearly there are a great number of things one could pick out as success stories in the last 25 years. But the one that is kind of close to my heart, because I am very interested in vaccines, because my current role includes having responsibility for very many elements of the UK vaccination programme, I would pick out Gavi, the Global Alliance for Vaccines. The fact that since that programme started, we have achieved vaccinating, I think it's something in the order of 700 million children who wouldn't otherwise have had access to vaccines, and the estimate is that around 10 million lives have been saved because of the efforts of that programme. So it may not be the only example, but I think, Shearer, it's the one I would personally pick out. It's very close to home, as you understand.
It's very impressive. Dr. Tedros, what do you think?
Yeah, I agree with John. I gave him the priority because he was my teacher when I was here 20 years ago. But he was a very young teacher, so he was also my colleague. One thing, I will come to the, I have already said, by the way, about the disease programs, the significant changes we have witnessed the last 20, 25 years. But one thing that helped that to happen is the partnership and global solidarity. I think HIV/AIDS is one very important model, actually, that brought everybody together. I remember when the HIV/AIDS outbreak was at its climax, people were dying a lot, especially in sub-Saharan Africa, and mainly breadwinners. And as a result, families actually breaking down, and then children going to the streets, and families losing hope. And that means when there is loss of hope in families, there is despair, then there is the national hope also, which is affected. And many countries that were actually influenced to that extent. And the most important thing that happened then is the mobilization of the whole world to do something. And then, of course, with PEPFAR, Global Fund, and all, people started to have access to treatment. And then started to regain some hope, which is a family hope, and then a national hope, and then becomes a global hope. So that partnership, that solidarity, I think the last 20 years has been really something that was a game changer. Although now we see that there is some, challenges with regard to partnerships and with regard to solidarity, which we have to really rethink. But I think that's most important, and that helped us with HIV, with malaria, and many of the vertical programs, as everybody knows.
You've both given some very impressive examples here, the vaccination and HIV/AIDS, how global cooperation has really moved public health issues forward. Is there anything over the last 25 years that you are slightly disappointed that hasn't gone as far as you would have liked it to go in the work that you've done?
If I may, I'll just come back onto the point that Tedros talked to about the changes in HIV medicine over the last couple of decades. And it reminded me that I'd actually forgotten. I remember from time to time that I remember as a junior doctor being involved with HIV patients in the UK. And I remember my time in Rwanda working in a mission hospital where the situation was utterly futile and desperate, and how much that's changed around now. So, that is a real success story. In terms of things I think that I wish we had taken note of earlier than we did, and that partly explains where we are now, I think I would pick out antimicrobial resistance, because 25 years ago it really wasn't recognized as the global public health threat that it has now become. We are, even if the figures are somewhat imprecise because of the time projection, the best estimates are that by 2030, if we don't deal with this, this will have an economic cost of $100 trillion around the world, and there will be a further 10 million deaths in that time related to infections that can't be treated, which, funnily enough, is the 10 million lives we've saved through the Gavi program. So that, for me, is very, very pertinent indeed. And it's not just the antimicrobial resistance, it's the fact that the way we use antimicrobials has created a commercial environment, and commercial environments are very important in terms of global public health. It's created a commercial environment where companies are finding it very difficult to invest in new classes of antimicrobials and bring them to market because the return on investment is not obviously there. And so, in addition to the AMR problem, we actually have a broken market in terms of bringing new agents into use.
A very worrying example. Do you have thoughts on that, Dr. Tedros?
Yeah. In terms of our progress in malaria HIV, which is commendable, but on the other hand, one thing that I believe we didn't do enough in the last 25 years is investment in health systems, especially primary health care. Be it for communicable diseases or non-communicable diseases, I think primary health care is the answer. And we have to build primary health care in order to make progress in many of the challenges we're facing, including, by the way, emergencies, even to be better prepared. It's the investment in primary health care that can help us. But that's what I saw as an opportunity lost, and we need to, from now on, I think we have to invest on primary health care, because when you invest in that, many of the indicators can be influenced. And when in WHO started aggressively advocating for universal health coverage, we also understand that the foundation should be primary health care. So that's one single, in addition to AMR, which I believe was something that we haven't invested, but going forward we have to do that.
I'm going to turn to the audience now and see if anyone has questions in the audience or any comments or any points you'd like to raise. There's a hand up in the first row and the second row. Over here in the first row and the second row. If we just take both of those questions and then we can have a discussion.
Jolene RDB, I'm Head of Division of Epidemiology and Public Health, which is where the Masters in Public Health course is based. And one of the things I think our students in the audience would want to know is what are the skills that are needed for the new public health professionals in the future?
Do you want to, shall we do Liz's question as well? And
right, thank you, Liz Frad, a nurse. It connects very well with that last question, actually. The first thing I would like to say is how the global nursing profession is welcoming and grateful for the investment that is now being put into nursing by the World Health Organization. The appointment of the first ever chief nurse, the investment into nursing now, and of course next year for it to be an international year of the nurse and midwife. My question is to Tedros, in particular in relation to nursing now, which still has time to run, but is beginning to make an impact. What would you see as being the most important lasting impact, which is sustainable as a consequence of that investment that is now being made? What is the long term, beyond the life of the project of nursing now? What would you see and hope for in terms of that investment?
shall we start with the skills question and then?
Shall I tackle that one to begin with and say that clearly public health is, as the years go by, less of its own discipline and more of a unifying concept that needs to fit into many disciplines if we are going to take a kind of one health, public health in all systems approach to improving outcomes for human beings. And I think one of the things that I would say has come back to me time and time again in public health practice, in the universities, in NHS public health, in the pharmaceutical and vaccines industries, and certainly in the last few years working at the Department of Health and Social Care. And that is the ability of public health people to work at interfaces between other scientific disciplines, and the ability of good public health people to be able to translate public health concepts into the language of transport, into the language of education, into the language of many other disciplines who have a role to play in public health. So maybe that's not quite nailing your question, but that for me is the nub of it really. Translation and work at interfaces.
Tedros.
Okay, thank you. I will take the second one, agreeing on the first one with John. On the Nursing Now campaign, I remember when Lord Nigel Crisp, I think Lord is Nigel Crisp, when we discussed the first time, the first discussion we had was exactly what you said. Okay, we have nursing now for a couple of years, then what? So we have to actually maintain some kind of movement as a result of the Nursing Now campaign. So that should result into something that will be delivered to help the people we serve. Because for me, the nursing campaign now is not for nurses. It's actually for the people they serve. Of course, it will have, in the process, some recognition to what nurses and midwives do. But even the bigger agenda and even the bigger campaign and movement is actually to help or to serve the people we serve in a better way. So that's why during our discussion with Nigel, we have agreed that the campaign continues with, as a movement for universal health coverage. As you all know, in almost all our countries, the role of nurses is very significant. And in some countries where there is a shortage of nurses, almost all the frontline facilities are staffed by nurses, and nurses act as a bridge between the community and the health service itself. And their role in health for all, in health services, is really, really significant. So during this campaign, preparing nurses to really be part of that movement in universal health coverage, in primary health care, as I said earlier, will be very important. So when we celebrate the year of nursing and midwifery in 2020, we will also chart a roadmap, a plan on how to actually use the big force that's being mobilized, because that energy has to be channeled or targeted to achieve something, and that's related to universal health coverage. So we believe it will continue as a movement to help us achieve universal health coverage by 2030. And we recognize also nurses not only as service providers, but as advocates for universal health coverage, as advocates for primary health care, as advocates for health for all. And that's why we want to use that energy being now mobilized towards that goal, because nurses and midwives have a bigger role in achieving that in many countries. But when I say this, without undermining the role of doctors, the role of pharmacists, the role of other health professionals. Then the other important thing, not only this, is we need to address the gap, the workforce gap. We have 18 million gap, all health professionals, and almost 50% of it is nurses. And this movement will also help us to fill the gap by 2030. So that's of course part of bringing the workforce we need to achieve universal health coverage. But that's very important. We don't want this campaign to be just a campaign, make some noise and then off. It has to be a campaign that will continue to deliver what we want based on the SDGs.
Thank you. Do we have other questions from the audience at the moment? Yes, we've got one over here and then one over here. If we can just take both of those and then we'll see where we go.
Mikhail Foster, I'm a nurse. This question is for you specifically, Dr. Tedros. With most climate scientists would argue that one of the ill effects or one of the side effects of the climate change crisis that we're going to be facing is that there's going to be a massive migrant crisis. And because of the fact that there will be rising sea levels and also famine in those regions. Now, with more countries becoming far more insular, how do you believe the WHO's role will be in regards to helping these countries, helping to manage the migrant crisis that will occur if climate change continues unchecked?
That's a very good question. The question over here.
Tony Marmont, I've got a simple question really. What is the view of a growing scourge on our society of Alzheimer's and dementia diseases, and how can we tackle it?
Where would you like to start with the specific question about migration, Tedros?
Yeah. I think it's the climate change you're taking as the root cause to migration. Maybe I would like to start with climate change. I mean, climate change affects the whole world, but at the same time, there are countries who are most affected than others. So I think it will be very important to serve, to help those countries who are disproportionately affected. And this, as you know, are the small island developing states, or the SIDS. And that's why we have in WHO a new initiative, a SIDS initiative on climate change and health. And that can address, all the factors or the challenges they will be facing, including what you said, because we want to have a comprehensive approach. And it will be very important to do both the mitigation and adaptation part of climate change, but at the same time, the other issues like migration and so on that you have indicated. So by focusing our energy on the most affected, although the whole world is affected, we can have better impact, and that's how we're going to address it. Of course, migration is not about countries that are affected by climate change only. Migration has different reasons, and the biggest migration is actually coming because of conflict. And many countries are being destabilized, starting from as you know, the Arab Spring, and floods of migrants and refugees because of the political problems, the security problems. So when we talk about migration, we have to address the root cause of the problem, including the geopolitical problem, which is affecting or having actually more impact. Then, of course, climate change as one factor can be addressed. So my suggestion is there should be a comprehensive approach to address the root cause of the problem and address. In WHO, we have, of course, a migration and health unit, and works on some activities, but I think it's an agenda, global agenda, which has to be given a serious attention and address the root cause of the problem, and that's why global solidarity will be very important to address the root cause of the problems behind migration, which is more political than anything else.
Thank you.
On age
and Alzheimer's.
Dementia and Alzheimer's. Yeah, clearly I'm not an expert in that area. I'm rather more on the infectious side. But what I will say is that I think you've picked out an example that is prominent, difficult, and looks like it's going to be more troublesome over time rather than less troublesome. But I guess as a public health person, what I would, and not as a dementia expert, what I would do is reframe that slightly and say, I see this as a very good example of the fact that we are living longer, and we are living longer with chronic diseases, disabling conditions for more of our lives. Well exemplified by simple surveys of the number of people in the UK, for example, who as they get into their 50s and 60s and so forth, become more and more dependent upon a number of medicines which they take daily because of chronic conditions. And I think that in terms, again, is a kind of wake-up call to the public health community that we have to look afresh at prevention. We have to look afresh at how we can reinvigorate that agenda. And as you know, my own government will be issuing a green paper on prevention at some point, we hope fairly soon, but we don't know the date yet. But that is an example of, I think, of the kind of reframing that now needs to happen alongside advances in healthcare and making healthcare more universal. We have to build on the prevention agenda and reinvigorate it in some way.
Thank you. I mean, you both talked a bit about some of the challenges that the world is facing in terms of global health, and you've also talked about some of the successes. I would be interested if you've come across research or areas of research where you think there might be breakthroughs that will help with global health. Are there areas that you've come across in your work where pushing the boundaries forward you can see might be transformative in a short period of time? if I flummoxed you with that question.
No, I don't think you've flummoxed us with the question, but it's a case of what we know because of our own kind of domains. And I suppose the one that the two vaccine-related examples that I would pick up are the published results, the research that clearly shows us that the HPV vaccination programs around the world are making a really significant difference and will make a very significant difference in the long term to rates of cervical and other orogenital cancers, and the impact that's going to have primarily on women's health, but as more and more countries adopt HPV programs for boys across the scale. And that really is a great example of how we are starting to think about vaccines in a way that target longer-term conditions rather than those infections that are sometimes immediately in front of us. And I think that's amazing. I recognise it's not a public health advance because of the issue of global applicability, but some of the work that is now being done in the gene therapy area is absolutely extraordinary, and for patients for whom they can benefit, and it's still relatively small numbers, completely and utterly life-changing in a very short space of time. One of the challenges I think that brings is for long-term conditions where the cost of healthcare is large and recurrent over multiple years. If gene therapies change that and take away that need, that's brilliant, but it does require some change in thinking about how that is funded, because there is a comparatively large upfront cost to avoid very significant recurrent costs over a much longer time frame. And that's something, as these new gene therapies become more commonplace, that I think it won't be in my working lifetime, but in others, of those of you in the audience who are younger, I'm sure it may well be in your working lifetimes that that problem has to be reframed in terms of how we can afford it.
Do you have any thoughts on this?
I think I agree with John, and I don't want to repeat that. Maybe a couple of things I would like to add is, one, the future of health will be influenced by digital health. So I think continued research on new technologies, especially on artificial intelligence, will be very, very important, because it's a double-edged sword. And of course, there will be advancement, and we need to check the other side too. And research to that will help us in regulating it at the same time, using it to the maximum, but regulating it too. So that going to be changing the way we serve. As you know, now health services is around institutions. It will be around individuals in the future. And self-care will be even more and more, because of digital technology, more and more dominant, and we have to prepare for that. And that's why WHO recently released the self-care guideline, but it will significantly be different in few years to come, when services around individuals or families rather than institutions. And that will be, of course, when we have a different scenario. So research towards that will be very important. And then on the health security part, I think we're very vulnerable to epidemics, especially airborne, like pandemic influenza, for instance. We're not ready. And many countries are actually failing. We have more fragile countries in the past 5 years than the world had had before then. And that increases vulnerability. You know what happened in Yemen even. I told you about DRC in Yemen. Cholera came back. the young generation didn't have any clue about cholera. It was long forgotten. But because of conflict, it came back. And that increases actually vulnerability, not just for Yemen and the neighboring countries, but for the whole world. And that vulnerability can expose the whole world to a serious epidemic. You remember after First World War, the Spanish flu, it killed up to 100 million people. And even now, we have weakest links, and we're as strong as the weakest link. And that vulnerability can actually, we may pay for it. So that's why, in addition to what I said earlier, strengthening the health system, especially helping in our weakest links, is one important thing. But investing in research, especially in new vaccines, to fight future outbreaks or pandemics will be very important, especially pandemic flu. If you ask me, one thing that wakes me in the middle of the night is that, because imagine we're struggling to control Ebola. Ebola is lousy. It actually spreads with contacts. It's not even airborne. But people even panic when you say Ebola. I have been to Congo many times. I'm not really scared of Ebola, but airborne, you know it. So we're really vulnerable. And anytime, it's a matter of when, not even if, it's a matter of when, that any pandemic flu can strike, and we're not ready. So I think research in that area will be very important, and with a sense of urgency, actually, which has to be done, because we're, as a global community, we're very vulnerable.
Okay, thank you. I'm going to go back to the audience now. Alex has something on Twitter. Do you have something on Twitter?
Yeah, I have a couple of questions from Twitter. The first is from one of our professors of health policy here. How do we make investment in public health as sexy as investment in bricks and mortar for politicians? And then the second one is a personal one, which is, what is the most frustrating part of your respective jobs, and what is the most rewarding?
Those are two big questions. Shall we do the personal bit first, the frustrating and rewarding parts of your job?
Yes. Well, that's easy for me because I still live in rural Lincolnshire and go to Whitehall every day. The most frustrating bit is undoubtedly the train journey every morning. But I know you want a real example too. And I think what can be frustrating is the sheer complexity of the system in which one now works. And with that come inevitably organisational barriers that don't need to be there. And, if you can get through those, there's some amazingly gifted people working in the public health system, truly amazing, truly talented. And, reminding yourself of why you go to work and what's important is very important in breaking that down.
Tedros.
Yeah. Frustrating. Of all things, I prefer to not take things personally. People ask me, you happy with this job? And I say, it's not a matter of happy or unhappy, because if I start doing that, then I could probably hurt myself. I could hurt myself. So I prefer to focus on the issue and not personalize it, and understand what it is, and try to bring a solution when a challenge comes. So anything that may frustrate means it's a challenge. Then how do I address that challenge is the question, by detaching it from me. And then it's not a matter of frustration or no frustration, or it's not a matter of happiness or not happiness, but something that has to be done in order to deliver better to the people who need that service. That if you start getting frustrated, it could be difficult. One thing, for instance, because of the post I have, some people ask me the same thing. Tedros, some people criticize you, and the WHO is criticized, so are you not frustrated? Then I say, why should I? Because WHO is very tall. It's one of the tallest, so you're visible. So people can just criticize or fire because you're visible. So you have to take it for granted. That's the issue, because you're visible, you have to serve, and you can be seen because you're tall, so you have to live with the criticism. But the most important thing is to understand what the people are saying, because there will be a point in it, and solve the problem, still detaching it, focusing on the issue. And that can keep my sanity, I think. So that's how I would like to take it. It's not a matter of frustration or not. But on the rewarding part, I see huge potential in WHO, incredible stuff actually, and I see that we can make some better contribution. Of course, WHO has been contributing for 70 years, but we can do even better. We have started transformation, and I have seen the level of energy of the staff in contributing new ideas. And when we started the transformation journey, we have agreed with the staff that change is not about moving boxes. Change is not about downsizing or saving money. Change is about new ideas that can change the organization, new ideas that can prepare the organization for today and the future, new ideas that can help the organization to better serve the people we serve. So it was like a floodgate opening. Many good ideas came from the staff. And almost all of the ideas that we're now poised to implement, many good ideas that will really change WHO significantly, came from the staff itself. And that's the most rewarding. An organization or a staff which is ready to change things and taking ownership and coming up with new ideas and energy. And that, again, stresses for me the importance of teamwork, the importance of a collective understanding of our organization, and preparing ourselves to help better. And that gives me energy and inspiration from the staff. So that's what I consider.
The other question, which I'm going to take the liberty slightly to rephrase, is really about getting government funding into public health. And I think there was a hint in that question that politicians like to open buildings and get glory from that. And the question is, what is it that would make governments, and I guess the UK government's in the frame here for the question, want to invest more in public health?
So I guess I'll kind of comment on that in several ways. And the first is to say that you all know as well as I do that public health is a long game. It takes a long while to change things, but they are sometimes dramatic in terms of changing things for a whole population or a large part of a population. And inevitably, that isn't as sexy, I think the word was from the question. It's not as sexy as, changing a child's life with invasive cardiac surgery in the space of 5 or 6 hours. It's never going to be in that space. And I think also public health, because it inevitably has a political dimension to it, is always going to be tied to politics to some extent, and is always, we just have to face it, going to be tied to the relative enthusiasm of any given government anywhere around the world on any given day or in any given time period. And that will wax and wane, and it will vary by country to country, and there will be this inevitable tension in countries with an underdeveloped health system where they put their money. And we simply have to advocate with good examples and real passion for the practice of public health that this is where you get your best bang for your buck, as it were. And in terms of Tedros's comment about WHO, I've had the privilege of working with the Nottingham Collaborating Centre over many years, the Collaborating Centre for Pandemic Influenza, and it is genuinely joyous and genuinely refreshing to go to Copenhagen or to go to Geneva and meet people from around the world who are posted there who are just utterly, utterly committed to their mission in terms of public health. It's very humbling and very refreshing too.
Thank you for that. That was great. I mean, we're nearly out of time, so I just want to ask one final question to each of you. And I want to put you in the shoes of each other's organizations. So, Jonathan, what does the UK government need from the WHO over the next few years? And Tedros, what does the WHO need from the UK government?
We're old mates, it's a bit difficult to...
You know, the previous question, may I, until you think about this one? On the previous question, actually, I just wanted to add to that. We tend to finance sexy projects or initiatives and fail to invest in the long-term or the strategic solutions. I think one thing we can do is, for instance, universal health coverage. It's a political choice. It's political. And that's why, take the UK, immediately after the Second World War, when its economy is still in ruins, it chose to have the NHS, which we're all proud of. And as a student, when I was here, I was covered through NHS, and I was saying, what a great system. And before that, I was in Denmark in 1988. It was actually in Denmark my first health insurance. I was covered for 1 year, although I was there for 4 years training, 4 months training. And Denmark was my first experience, and then UK. And I said, this is excellent. And at the same time, doable. And that I think the whole world should move towards that direction. And in both countries, there is one factor. It was a political choice. They chose to have that kind of system. And many countries who do similar things, it's a political choice. Then if it's a political choice, it's very important that the public is aware, the society is aware, and makes it a demand, and then for the politicians to deliver. That's, I think, one important lesson I have seen. And with that political commitment that comes because of the demand from the community, I think it can happen, even if it's not sexy, because of the political nature that will put pressure on the politicians themselves.
Thank you.
Then on what do we want from
my final question, just a sentence or two from each of you.
I think the UK government recognises that WHO is an extremely strong force for good in the world of public health, that it has the very strongest voice across the international community, and that we are utterly dependent upon you for firm, decisive global leadership and influence on public health matters. And put quite simply, we want you to continue to do that.
What do you think, what should we be doing in the UK that would help you?
From UK, maybe from my own experience, actually. This is in 2009, around that time, 2010, and so on. We were discussing about this architecture of financing. And it's basically about who sets the priority of a country, actually. It's not even the financial architecture. Because when I was Minister of Health in my own country, I had difficulties because I had to prepare plans to request money from different donors. Then we have to do the budgeting and so on based on the requirements of each and every donor. And then we have to report to all donors one by one based on So imagine how many plans you prepare, how many budget systems you follow, which is very confusing, different ones, and then how many reports you prepare. Then this movement started, one plan, one budget, one report. And at that time, Prime Minister Gordon Brown was the Prime Minister, and he took political leadership actually in pushing donors to agree to one plan, one budget, one report, and giving money to countries, unearmarked money, so they can use it based on their priorities. Meaning helping countries to own their own business, basically. That was a game changer in Ethiopia. Not only the first year of the implementation brought more than $180 million in 1 year, that's the first year, but at the same time, that money was at our disposal to use it based on our own priorities. And that means the donor is saying, I trust you, use it based on your priorities, and what we want is impact. That kind of relationship is very important. So UK did it. I am a witness. It can be done in each and every country. So the issue is, how can UK help other countries, also influence other countries to move in that direction and empower countries? You know, believe me, you go to any country, they know their problem. They know the root cause of the problem. They know the solution. They don't need even to be told. We don't need earmarked funding for countries. We have to empower them. That's when they can release their energy, because when they own something, ownership means you can do your best to make it happen too. With ownership comes commitment. With commitment comes result. If I ask one thing, that's it. Even without increasing the funding level, changing the quality of the support itself will be very important. But not only at the country level, then I will ask the same thing for WHO and other international organizations. Maybe the audience doesn't know that in WHO we manage close to 3,000 grants. The same problem that I told you that we face at country level. But this is, as we speak, I manage more than close to 3,000 grants, small pots, that comes from different donors. And then imagine planning based on each and every donor's requirements, and then following their budget system, and then reporting to each and every donor. And 46% of the funding is less than $500,000. Imagine how crazy and messy the situation is. And above all, most of it is earmarked, so we're not empowered even to use it based on the priorities. And that doesn't help to bring impact or to deliver better for the people we serve. So be it at country level and global level, that kind of empowerment and trust should come. And because that gives more energy to deliver on results. And that's what I would ask, because UK did it before. I'm a witness. It can be done at country level, and it can be done at global level. Thank you.
Thank you very much. And I think we'll close on those inspiring words. Can I just say thank you very much to Tedros and to Jonathan for giving us such an interesting and, in some cases, slightly scary set of things to think about global health. Can everyone express their appreciation, please? Thank you all very much for coming. Thank you.